Good afternoon. My name is Marsha Krise, and I am here today to talk to the Division of Health and Human Services about a subject that is very dear to my heart. I'm a registered nurse certified in maternal and newborn care at a large facility in Delaware. I work both on an antepartum as well as a postpartum floor in a hospital that has approximately 6,500 deliveries a year. I am testifying before you today representing the parents of newborns nationwide who are at risk for critical congenital heart disease, as well as the myriad of healthcare professionals who have taken care of these infants. I come before you to discuss a subject that is very dear to my heart. I am hoping that after hearing my testimony that you will become motivated to take action and that you will approve a national recommendation for a newborn screening program. Let me begin. Several years ago, a very close friend of mine delivered a beautiful baby girl at our hospital. Due to the unfortunate fact that our hospital lacked a newborn screening tool that I will discuss later, she was discharged home with the belief that she was in perfect health. But within a few days of coming home to an ecstatic family, she was brought into the emergency room limp and lifeless. Despite vigorous resuscitative efforts, she did not survive. An autopsy later revealed that she suffered from what is now called critical congenital heart disease. A simple 3-minute test could have saved this family from the excruciating experience of burying their newborn. Congenital heart disease is the most common birth defect and affects approximately 8 per 1,000 births each year. Critical congenital heart disease, which is a severe form of congenital heart disease, has an incidence of about 2.5 to 3 per 1,000 live births. These more serious defects can cause significant morbidity and mortality and account for almost 40% of deaths in children with congenital anomalies within the first year of life. Although numerous advances in care have resulted in a reduction in mortality, timely diagnosis remains a difficulty for these newborns. Delay in diagnosis may have significant adverse implications. In fact, many cases diagnosed after discharge were in shock at the time of readmission. The good news is that pulse oximetry has been recommended as a potential newborn screening tool to test for critical congenital heart disease. In a study conducted by the American Academy of Pediatrics and the American Heart Association in 2009, it was demonstrated that pulse oximetry screening could improve the detection of critical congenital heart disease. This study used a saturation level of 95% as a cutoff value for additional consultation or evaluation. Pulse oximetry is a simple bedside test used to determine the amount of oxygenation in a baby's blood. It also can detect the baby's heart rate. Low levels of oxygen in the blood can be a sign of critical congenital heart disease. The test is painless and only takes a few moments to complete. Screening can be performed when the baby is between 24 and 48 hours of age. A disposable probe is attached to the meaty aspect of the palm of the right hand near the 5th finger or the pinky finger, approximately right there. The probe is then used to measure the oxygen saturation after a steady waveform is achieved. The probe is then moved to the right foot, again using the meaty aspect of the foot near the 5th metatarsal or pinky toe. Another reading is obtained after the site has achieved a steady waveform. The results are considered negative if the saturation level is greater than 95% for both the right hand and the right foot, and if there is less than a 3% difference between the two readings. If the oxygen saturation is ever less than 95% for either the hand or the foot, or if there is greater than a 3% difference between the two readings, the test is considered positive and warrants further investigation and follow-up by a pediatrician. I come before you today to ask you to support a nationwide screening tool to test for critical congenital heart disease and to eradicate the deleterious effects of undiagnosed critical congenital heart disease. I realize that the first point of contention towards this proposal would be the cost and training involved to perform this test. The cost to implement such a screening tool would be minimal due to the fact that most hospitals already have pulse oximetry machines. Disposable probes are also inexpensive compared to the cost of treating a sickly child diagnosed late after discharge from the hospital. Reusable probes are also available if cost were to become an issue. Another point to consider would be an individual hospital's testing capabilities. If a newborn tested positive in a small rural hospital that did not have access to, for instance, an echocardiogram machine, and if the infant were stable, then the parents could take the child to a larger facility to have further testing performed rather than have the child transported in an ambulance in order to cut back on costs. In a study conducted at Holy Cross Hospital in Silver Springs, Maryland, from January 2009 until May of 2010, adequate training was achieved after nursing staff attended a 1-hour educational in-service. I know that this is just one of many proposals that you are considering at a time when budgets are stretched to the limit, but I feel that this simple screening tool can not only save lives, but can save money in the long run. This is because it will be less expensive to treat a stable newborn rather than treating a newborn on the brink of death. Thank you for your willingness to hear my testimony. I hope that this subject has created a desire to implement the newborn screening tool in hospitals nationwide.